Good afternoon. It's always a little bit intimidating being the next panel after lunch, or kind of mid-afternoon, right? So I hope you find this informative and helpful, particularly as I know that a lot of organizations are wrestling with what to do with regard to reimbursement and access issues. Just to share a little bit about myself, over the last 18 months to 24 months, it became acutely aware to me as I interacted with patients that were being impacted by both Medicare and Medicaid access issues, that there are some really actionable things that could be done in the space to create solutions. And as you listen to the patient stories and their patient experiences, many of the patients that I was working with and talking to had undergone years and decades of misdiagnosis, wrong diagnosis, procedures, and other things before they finally got to the right diagnosis. And then, by the way, they found out not only did they get the right diagnosis, there was a therapy. But what they learned quickly was they may have had coverage, but they didn't necessarily have access to therapy. And so some of the stories that were shared with me over the last 18 months or so were heartbreaking. And so we started thinking, how can we actually come up with solutions? And I'm going to talk about that at the end. My last couple slides are a couple of specific things that the Rare Access Project is involved with, particularly in Medicare, to help patients overcome that hurdle so that they can not only have coverage, but potentially access to the therapy that they need. So I'm going to provide just an overview, and in the time that we have, we really don't have a lot of time to go very deeply into the Medicare program. There's going to be a lot of things that I'm not going to be able to cover. So what I'm going to try to do is highlight the various sections and pieces of Medicare, and then please feel free to follow up with me either after or later if there's more detailed information that I can help provide for you. But what is interesting to me is that Medicare is actually something that has been debated in the US since the 1930s, and it actually came to fruition in the 1960s. And so when we talk about the Medicare system or the Medicare program, we're talking about a system that actually was designed 50 years ago. And sometimes we don't really think about that. And think about the revolution of medicine that's occurred and the revolution in healthcare that's occurred over the last 50 years. In the 1960s, rare diseases were almost unheard of. Actually having therapeutic treatments in general were not broadly heard of. And so over the last 50 years, we've had a complete revolution in healthcare and how we access that healthcare. So what I'd like to do is start just with an overview where we can talk about the various components of Medicare and give you a kind of a general understanding of what those components do and how they work. So Medicare Part A is something that most Americans pay into. It's part of your standard payroll deduction. It's something that, you know, as soon as you start work, you're going to have your Medicare deduction taken out of your paycheck. And because of that, most Americans don't pay a premium when they access Medicare Part A. Now, Medicare Part A is the hospital benefit or medical services benefit. And if you don't get that benefit, for example, let's say that you're self-employed or you work for a group where you opt out of that Medicare tax benefit, you would be required to pay a premium, okay? And so that's important to understand. Most of the folks that you probably help and work with are going to qualify for their Medicare Part A. And as you can see, it is very hospital-focused with a skilled nursing component. And the hospital focus, again, it really has a very well-defined benefit and well-defined cost structure. So you're going to find that Medicare Part A is something that hopefully with planning and understanding that people will be able to approach it and really understand how much it's going to cost them. Medicare Part B is a little bit more complicated. Medicare Part B covers medically necessary services, but for many rare disease patients, particularly in rare oncology, it also provides a handful of outpatient medicines. And those medicines fall under the same conditions as the rest of Medicare Part B, which is 80% that the government pays and 20% that the patient pays. And here you can see the list of services and some of the things that are covered under Medicare Part B, from clinical research, ambulance services, a lot of kind of front and center type services that someone who's a beneficiary of Medicare would be able to access. But here's where it gets a little bit more complicated. There is a premium associated with Medicare Part B, and the average premium amount is $135, depending on your income. So it gets more complicated as people reach various thresholds in Medicare Part B. So encourage beneficiaries who are looking and seeking services, help with Medicare Part B to do two things. One is find out what their premium would be, and that would entail them reaching out to the Social Security Service, and they'll be able to find out exactly what they qualify for. The second is to look at their Medigap coverage. Now, by Medigap, remember I said that the government pays 80% of your Medicare Part B related costs, and the beneficiary is responsible for 20%. Medigap insurance coverage allows that Medigap company to come in and pay for that gap cost. Now, there is cost associated with that. From a monthly premium, the Medigap program may also have particularly deductibles and things that they want to have met. But in general, and in most cases, it will save beneficiaries money to have a Medigap plan. And so encourage beneficiaries who are working with your organizations to really do their homework on which Medigap program will help them for the services that they need. Okay, that's really, really important to do up front. So remember, the Medicare beneficiary is going to be typically responsible for 20%, and with some of the rare disease therapies that they may be able to access through Medicare Part B, that 20% could be very expensive. So helping those beneficiaries really understand their Medigap choices, the parameters of programs that they could select from, and as well as then the cost is really, really critical to help protect them from the costs when they hit the Medicare Part B program. Okay, Medicare Part C, or Medicare Advantage. This is a program that actually takes and coordinates some of the care within the Medicare system. So they would still have Medicare Part A, which is a service that they've already got, but now they have a managed care organization that can help them with their coordination of the other services and help them to not only have better oversight and coordination of the care, but also some of the services that aren't necessarily traditionally offered through Medicare can be offered through a Medicare managed care plan. And so this is an important option when beneficiaries, whether they're seniors or long-term disabled, as they look at their options, Medicare Part C sometimes will be able to save them money and provide a broader range of services that they could then access under that monthly cost that they would get through their Advantage plan. Now, some parts of the United States don't have the same selection and the same services, so it's really important as you have rare disease patients who are moving towards Medicare coverage, whether through disability or through aging into the system, that you work with them to understand their Medicaid managed care options as well as their Part B options, because they may be able to save money by opting into Medicaid or Medicare managed care. So all of the original Medicare services except hospice is covered under Medicare managed care. The emergency coverage, the urgent care, as well as in many plans, dental, eyeglasses, or wellness programs. Most Medicare Advantage plans include Medicare prescription drug coverage, and so as you look at that, have them also, and we're going to talk about Medicare prescription drug coverage in just a moment, compare all the pieces and make sure that they get a comprehensive snapshot so that they understand where the costs will come from for them when they hit the Medicare system. In addition to your B premium, you usually pay one monthly premium for the plan's medical and prescription drug coverage. And again, for many seniors, just that coordination of what's owed and who to pay it to every month is a little bit simpler sometimes than having to juggle your A costs, your B costs, and your D costs. So again, it's something to look at, something to benchmark against the other options that they have in the system, and something that's important for them to understand, particularly from a cost perspective. Also, when you're looking at the plans, remember these are various managed care plans that will compete with each other in the marketplace. And so from year to year, their benefits will change. So it's important to look at the benefits every year. And usually that means try to look at the benefits beginning in October and November, because that's when open enrollment will begin. And so you want to make sure that as beneficiaries move from year to year then, that they keep an eye on the benefits that are offered through their Medicare Part C plans. And that will be really important so that they don't all of a sudden are surprised January 1st that something they were counting on is no longer covered. Okay, now I want to spend a little bit of time in the Medicare Part D prescription drug benefit. This is a benefit that was crafted in the early 2000s. And when they were putting together the benefit, I want you to think about that in 2002, 2003, when this was being debated in Congress, there really wasn't the revolution that we've seen in rare disease medicines. You only had a handful of oral rare disease medicines. And over the past 12 to 15 years, there's been a revolution in rare disease medicines where now you have subcutaneous injections, you have oral medicines that can be covered under the prescription drug benefit. And so it's really important as you work with populations that are moving into the Medicare system that they understand their Part D plans and that they understand where the costs are and they understand what the plan is offering from year to year. And we'll get into that in a second because it can be very complicated. So beginning in 2018, the initial deductible for Medicare Part D plans rose to $405 a year. Now this means that that's the amount of the deductible that you pay before the plan begins covering under the benefit and begins the cost sharing part of it. Many Medicare Part D plans exclude the lower costing Tier 1 and Tier 2 drugs from the deductible. So your beneficiaries may get a benefit a little bit sooner for those lower costing medicines. Often many rare disease medicines are in the higher specialty tiers, and so they won't get the same benefit from the orphan disease medicines. However, as they look at the whole, make sure that when you talk to your beneficiaries that they understand what medicines that they are and what they might need so that they can balance this out. Now, the next part that's really kind of confusing is what's called the Medicare coverage gap, or the donut hole. And we've all heard about it, and from year to year it moves. Since 2010, with the Affordable Care Act, there was a major effort to begin to close the donut hole so that the beneficiaries wouldn't have to pay so much out of pocket. And beginning in 2018, that donut hole again closes with the beneficiaries being responsible for a smaller share in the donut hole. So the coverage gap discount begins when you and your plan have reached $3,700. And that $3,700 then moves you into what's called the coverage gap, where in 2010, when the Affordable Care Act was first designed and then 2013 when it was implemented, that would have been 50% that they were responsible for in a donut hole. Beneficiaries can also access help in the donut hole that will help them pay for some of these things. And I provided the link here to make sure that as you talk with members of your organizations who are beneficiaries, that they can go and find this information. So if you have challenges paying for the out-of-pockets in the donut hole, please go to medicare.gov to this link, and it will help you find additional programs that can help them pay for their coverage in the donut hole. The coverage gap ends at $5,000. So that $1,250 that they're responsible for theoretically ends at $5,000. But then they get into what's called the catastrophic coverage gap. And we'll talk about that in just a moment. But that changes their benefit yet again. So it's something to keep in mind as you're looking at plans up front and you're looking at ways to help beneficiaries cover themselves throughout the year. Okay. So as you can see, the donut hole increased this year so that they're going to get coverage up to 56% of generic costs in the donut hole. And for brand name drugs, their coverage assistance will rise from 60% to 65%. Now that rises again next year, but the goal is by 2020 to completely close the donut hole so that the patient moves more seamlessly in the Medicare Part D system. Okay. So catastrophic coverage begins when a beneficiary has reached an out-of-pocket cost or a true out-of-pocket cost of $5,000. And this means that that patient is then responsible for a portion of the cost sharing in that catastrophic coverage. So they will have their initial coverage up to the donut hole. They will then get some assistance in the donut hole, hopefully closing that by 2020. And then we have the catastrophic, where they are either responsible for a set amount, which is $835 for brand drugs or $335 for generics, or 5%, whichever is higher. Okay, and that's kind of the kicker, isn't it, the 5%? Because once the beneficiary reaches the catastrophic, that 5%, depending on the medicine that they're on, can become quite large, and particularly for very rare diseases. So patients can qualify for help in the catastrophic, and there is an extra help program that's offered through CMS, and that can help them through the catastrophic with that copay. And there's a couple of things that they have to qualify for in order to get that additional assistance. The first is they have to have full Medicaid coverage. They can get help from their state Medicaid program in paying their Part B premiums, or they get SSI benefits. So work with the beneficiaries to understand how they would fall in those parameters so that they can have go back to CMS and Medicare and qualify for extra assistance. If you don't qualify for that, some states also have programs that will help with filling some of the gaps here. So go back to the various state drug programs. For example, New Jersey, New York, Pennsylvania, and other states have assistance programs for Medicare beneficiaries that your beneficiaries may qualify for as well. And have them go back and work with those programs to see if they qualify or how they would become qualified. So beyond that, can anybody else help them? That's a really interesting question because there are nonprofit foundations that provide assistance. NORD, for example, runs a nonprofit foundation which helps Medicare Part D patients with patient assistance. And there are other nonprofit foundations that have what are called funds that can be used to help with this 5% catastrophic copay. So many of these foundations run under guidance from the Department of Health and Human Services Office of Inspector General. So there are guidelines. Was there a question? I'm sorry, I can't hear. Plan F? Oh, well, I talked about Medigap in the Part B. Is that?
I have a question over here as well. Maybe after.
Yes, my sister had mentioned something with her husband, and they explained to her about a Plan F.
Yeah, I'm not sure what a Plan F would be.
Well, it's something where they're getting their prescriptions at Walmart for $4 per prescription.
It's Medigap.
So that might be,
It's the same as
could be the
Medigap
Medigap plan that I talked about under
Okay.
Part B.
Okay.
And it also could be that some of the companies do also offer some drug assistance programs, and there are state drug assistance programs
Yeah.
that we talked about. So,
I just didn't see a Plan F up there.
yeah.
So,
Thank you. Can you hear me okay?
Yes.
Okay. My name is Mark, and I'm with the International Pemphigus and Pemphigoid Foundation. And we work with a lot of patients that are using off-label drugs, and they've been on these drugs for a number of years, 10 years sometimes, and now they're having a difficult time getting these drugs, they're off-label again, approved through Medicare because they're not FDA approved. Can you tell me why these patients are having a difficult time getting these drugs approved through Medicare, even though they've been on these life-saving drugs for 10 years or more, and now all of a sudden they're having a difficult time getting approval?
Do you know which portion of, so for example, Medicare Part B is run through regional carriers. And the regional carriers make local coverage decisions based on compendia, based on labels, based on other things there.
So if they've changed the compendia, even though these patients have been on these drugs for numerous years, if they change the compendia, then a patient will now not have access to a drug that is saving their life?
Or potentially if they made a decision based on that. In Medicare Part D, it could be a plan determination. And so Medicare Part D is run by Part D plans, which are often run by, bigger carriers like Aetna, United, and many others. And if they make a formulary decision, sometimes there will be an access outcome at the other end.
So the carrier is the one making that final decision?
Yes, many times it's the carrier or the plan, and they may be just adjusting copays, they may be moving it around on the formulary, or if they see something else that they consider better or cheaper, they may be making a formulary decision to cover that first. There's all sorts of things that can go into a decision-making at the plan side.
Okay, so now that we know what is being done wrong for the patient, how do we fix that as patient organizations for those patients that now no longer have access to their drugs because the carrier has made an indiscriminate decision based on God knows what, that these patients now no longer have access to life-saving drugs that they've been on for years?
So some of the biggest things that you can do is identify which plans are making the coverage and which ones they signed up for. And then begin to advocate with that plan. Help educate the beneficiary so that they can weigh in. Help them educate their physician so that the physician can weigh in. Many of the plans have appeal processes in place where the patient can appeal through, and their physician is key to that. So remember that, the physician is key. And many of the physicians' offices, this is new territory on how do they advocate on behalf of patients with plans. They see lots of patients throughout the course of a day or a week, and they're handling a lot of paperwork at the back end as well. So having an educated patient up front is critical for them to be able to educate their physician, their physician's office, and then educate the plan, and then work through the appeal process and have their physician document, their diagnosis code, document, natural history or family history, document the tests, the diagnostics that were used to come to that determination for the disease that they need the access to the medicine for, because that's what the plan's going to push back on. And so the better educated they are up front, the better they can make that argument with a plan that they need access to that medicine.
Okay. And is there anything that Medicare can do on the overall level to help try to influence those carriers?
If you find that happening more than just kind of a one-off, you can go to CMS and get a national coverage decision. The road is a little bit more arduous,
Right.
And it takes a very focused effort. But if you find that you're in that position, reach out to even the national umbrella organizations, reach out to NORD, reach out to some of the others. Global Genes is also very good at helping put together the tools for some of these things. But reach out to them because they can help you navigate that in a very, very kind of technical way. But there are other routes through CMS. They're just a little bit more arduous.
Okay, thank you so much. Appreciate it.
Okay. So I'm going to move through these fairly quickly. The foundations can help provide some of that coverage as well. So do some research up front on some of the foundations that may offer assistance with prescription medicines. That will be really, really important. Now, some of these funds run out of funds throughout the year. Some of them cap the number of enrollees. So it's really important that you as organizations are helping your patients monitor that so that they can get some of this additional assistance. Now, I'm going to just kind of wrap up here really quickly because I did tell you a little bit more about the Rare Access Project up front, where we're looking for specific solutions on how to help patients. We have been working with a project now where we have legislative language that would cap out-of-pocket costs in Medicare Part D for patients that hit the catastrophic. And this language, actually Lauren from Senator Hatch's office this morning has been very, very helpful in terms of our focus, helping understand the impact of our legislation and moving that forward. We are working on moving that through Congress as a demonstration project. Many of you will remember a couple weeks ago in the president's budget, he highlighted capping out-of-pocket costs in Medicare Part D. As many proposals, that may not go very far, but it was a marker that there may be some running room here to use rare diseases as kind of a model initiative to show the impact and the benefits of helping patients access the therapy that they need in the Medicare Part D system. So there is a coalition working on that. That includes not only life sciences companies and stakeholders, but also rare disease patients, organizations, and stakeholders as well. So again, just in conclusion, I mentioned this as we went through Part A, Part B, Part D, and Part C. Educating your beneficiaries is going to be very, very important. The rare disease patients I've worked with over the past few years, again, by the time they get to their rare disease diagnosis, they're exhausted. They're exhausted. Their physician doesn't necessarily know what to do. He's seen one patient with their disease in his lifetime, in his practice. And so they need to understand that they can be empowered as advocates to make change, whether it's advocating with a plan, whether it's advocating with a local coverage decision, or advocating in Washington, D.C., that a well-educated patient who has a support network, they can make a difference. And I just want you to remember that's critical as they hit the Medicare system, so that you can help them overcome some of their exhaustion, overcome some of their frustration and disappointment. and help them get access to the medications or the health care that they need. So thank you, and we'll turn it over tomorrow.